আসসালামু আলাইকুম ওয়া রাহমাতুল্লাহ। এখন আমরা একটা নতুন জিনিস ট্রান্সপ্লান্টেশন ইমিউনিটি এবং তার সাথে ইমিউনোসাপ্রেসিং এজেন্টস এই দুটো নিয়ে আলাপ করতে চাচ্ছি। Transplantation immunity and immunosuppressants. Bismillahirrahmanirrahim. Assalatu wassalamu ala sayyidil anbiya wal mursalin. Rabbi zidni ilma, Rabbi shrah li sadri, wa yassir li amri wahlul 'uqdatan min lisani yafqahu qawli. আমরা হিস্ট্রি দিয়ে শুরু করতে চাই। In 1967, on December 3, South African Dr. Christian Barnum performed the world's first human-to-human heart transplant at Groote Schuur Hospital, Cape Town. The recipient was Louis Vaskanaski. Donor was Denise Darvel, a young woman who was run over by a car on 2nd December and had been declared brain dead after suffering serious brain damage. The operation started shortly after midnight on a Saturday night and was completed the next morning just before 6 a.m. It took 9 hours. Transplantation. What is transplantation? Trans means changing position or transfer. Plantation means to implant, implantation, and other name is graft. There are two definitions. When there is transplantation and transfusion. Transfer of solid organ or part of it or living tissue from donor to recipient is called transplantation. For example, kidney, cornea, bone, skin, etc. Transfer of fluid tissue within individuals is known as transfusion, blood transfusion, fresh plasma, platelet, etc. Transfer of any part of an organ by artificial material is known as prosthesis. So we found three terms: transplantation, transfusion, and prosthesis. What is the indications for this? Number one indication is failure of functions of vital organs, liver, kidney, etc., reconstruction, remodeling, cosmetic, and rehabilitation. Types of transplant. Most important type is autograft, very easy. Then isograft, allograft, and Xenograft. Autograft is self-tissue transferred from one body site to another in the same individual. Usually it is done in the burn patients. Isograft is tissue transferred between genetically identical individuals. Kidney transplant from twin brother like that. Isograft is genetically a twin brother. Allograft is tissue transferred between genetically different members of the same species. And Xenograft is tissue transferred between different species. Transplantation, is it an immunological field? Yes, unquestionably, transplantation is an immunological field because transplantation needs proper tissue matching. Otherwise, grafted tissue in recipient will be recognized as foreign antigen and damaging immune response will be produced, resulting in rejection. Immunology of transplant rejection. What are the components that take part in graft rejection? Number one component is antigen presenting cells because they recognize and present the antigen. Dendritic cell, macrophage, activated B cell. B cells and antibodies, preformed antibody, natural antibody, preformed antibody with prior sensitization and induced antibodies. T cells and other cells, natural killer cells, monocyte, macrophage, and T cells that express natural killer cell associated marker. The immunology of allogenic transmission. Recognition of transplanted cells that are self or foreign is determined by MHC that are inherited from both parents and expressed as codominantly. You know about MHC. Alloantigens elicit both cell-mediated and humoral immune response. How the alloantigens are recognized? There are two ways. One is direct and another one is indirect. Direct way is just intact from the donor recognition of intact MHC molecule displayed by the donor antigen presenting cell in the graft. You know, all nucleated cell have got MHC molecule. So donor cell have also an MHC molecule, and this MHC molecule displayed by the donor APC is recognized by the recipient. And it involves both CD8 and CD4 cell. Allogenic antigen presenting cell in the graft, and they present the donor MHC. So T cell recognizes, T cell of the host, unprocessed allogenic MHC molecule on graft antigen presenting cell. This is direct presentation. Indirect presentation is donor MHC is processed and presented. Donor presented by recipient antigen presenting cell, and basically donor MHC is handled like any other foreign antigen. It involves only CD4 cell. So one is direct and another was. There is presentation of processed peptide allogenic MHC molecule bound to self MHC molecule. Direct one was direct presentation by donor APC, but this is by recipient APC. Activation of alloreactive T cells and rejection of grafts. Donor APCs migrate to regional lymph nodes and are recognized by recipient T helper cell. This T helper cell in the recipient induce generation of delayed type of hypersensitivity and cytotoxic T lymphocyte, then migrate to the graft and causes the graft rejection. Role of CD4 and CD8 molecules. CD4 differentiate into cytokine producing cells, and the main function of CD4 is to help the CD8 cells and damage graft by reactions similar to delayed type of hypersensitivity, and CD8 cells are activated by the cytokines liberated from CD4 and they kill by direct pathway. CD8 cells activated by indirect pathway are self-MHC restricted, selecting donors. First of all, the same person for skin and vascular graft, this is known as Isograft. Identical twin for kidney transplant is the best. Others are parent, brother, sister, close blood relation, and unrelated but MHC and blood group matched. Third, other animal for heart valve graft, cadaver for cornea, living individual for bone graft and cartilage. There is no need of MHC matching for cornea and cartilage. What are the role of cytokines in graft rejection? In interleukin 2, gamma interferon, tumor necrosis factor B, they are very important mediators of graft rejection. Interleukin 2 promotes T cell proliferation and generation of T lymphocytes. Gamma interferon is central to the development of delayed type of hypersensitivity response, and tumor necrosis factor B has direct cytotoxic effect on the cells of the graft. A number of cytokines promote graft rejection by inducing expression of class 1 or class 2 MHC molecules on the graft cell. And the interferon alpha, beta, gamma, tumor necrosis factor alpha, tumor necrosis factor alpha, all increases class 1 MHC. And gamma interferon increases class 2 MHC expression as well. What is the fate of a transplant? This transplanted organ or tissue undergo pathological changes due to short-term or long-term immune reaction by donor's immune system. And this is known as rejection. So ultimate fate of any transplant is rejection. And successful transplantation is claimed when transplant remain functional up to at least 5 years. So 5 years survival, 5 years survival is the success. What are the types of rejection? There are 3 types of rejection: hyperacute, acute, and chronic. Hyperacute rejection occurs within minutes to hours of surgery due to antigen-antibody reaction by the preformed antibody in the recipient circulation. Actually, hyperacute rejection occurs before the surgeon takes off his dress. Acute occurs within days to weeks. Typical primary immune response, mainly cell-mediated, may also be antibody-mediated. Chronic, it occurs after months to years after surgery. Cause is unclear, slowly progressive reaction, and there are recurrence of episodes. Let us a little bit about hyperacute rejection. Characterized by thrombotic occlusion of the graft, begins within minutes or hours after anastomosis. Pre-existing antibodies in the host circulation bind to the donor endothelial antigens. They activate complement cascade, and so preformed antibody, complement activation, neutrophil migration, inflammation, thrombosis, all these are the components of hyperacute rejection. Acute rejections, vascular and parenchymal injury mediated by T cells and antibodies that usually begin after the first week of transplantation if there is no immunosuppressant therapy. And this is about, it occurs 30% for the first 90 days. Acute rejection, it is both T cell, macrophage, and antibody mediated. There is endothelial and myocyte damage and inflammation. Chronic rejection occurs in most solid transplants like heart, kidney, lung, and liver. Characterized by fibrosis and vascular abnormalities with loss of graft function over a prolonged period. Chronic rejection is usually cell-mediated. There is concentric medial hyperplasia and chronic delayed type of hypersensitivity reaction. Tissue and organ transplantation. Today it is possible to transplant many different organs and tissues, including bone marrow transplantation, organ transplantation like heart, kidney, pancreas, lung, liver, and intestine. Tissue include bone, cornea, skin, heart, vein, cartilage, and other cancer. But the most common transplantation is blood transplantation. Bone marrow transplantation, it is used for leukemia, anemia, immunodeficiency, especially severe combined immunodeficiency syndrome. About 10 to the power 9 cells per kg of host body weight is injected intravenously in the recipients. And recipient of the bone marrow transplant is immunologically suppressed before grafting. For example, leukemia patients are often treated with cyclophosphamide and total body irradiation to kill all cancerous cells. Because the donor bone marrow contains immunocompetent cells, graft may reject the host. This is called graft versus host disease. This is against the usual phenomenon of rejection. So graft versus host reaction, we should discuss. Reaction of donors transplanted tissue, not recipients, containing active immunocompetent cell against recipient tissue. It occurs only in bone marrow transplant because bone marrow recipient undergo whole body irradiation to cripple their own immunocompetent cells. Some donors' marrow contain all types of, since donors' marrow contain all types of immunocompetent cells, macrophage, B cell, and T cell. These are capable of producing immune response towards recipient tissue. So, graft versus host disease is a complication of bone marrow transplantation caused by the reaction of grafted mature T cell. There are acute and chronic graft versus host disease. Acute, characterized by epithelial cell death in the skin, GI tract, and liver. Chronic, characterized by atrophy and fibrosis of one or more of these same target organ as well as the lungs. Heart transplantation. First heart transplant in South Africa by Christian Barnard in 1964. 1 year survival rate is more than 80%. HLA matching is desirable but not often possible because of the limited supply of the heart and urgency of the procedure. Lung transplantation, first attempt in 1963 by Hardy and co-workers. First successful transplantation by Toronto Group in 1983 in conjunction with heart transplantation to treat diseases such as cystic fibrosis and emphysema or acute damage of the lungs. First year survival rate is about 60%. Kidney transplantation, diseases like diabetes and various types of nephritis can be elevated by kidney transplantation. Survival rate is more than 90%. 25,000 candidates are waiting for kidney transplantation. Liver, if treated, it treated the congenital defects and damage from viral hepatitis or chemical agents. Liver, 1 year survival exists 75% and 5 year survival is 70%. Pancreas transplantation offers a cure for diabetes mellitus. Graft survival is 72% at 1 year. Overall goal to prevent the typical diabetic secondary complications. Skin grafting is used to treat burn victims. In severe burn, grafts of foreign skin may be used and rejection must be prevented by the use of immunosuppressive therapy. Genogenic transplantation. A major barrier to genogenic transplantation is the presence of natural antibodies that cause hyperacute rejection. Clinical attributes. We will have to select recipient, appropriate recipient, and then the recipient should be screened for preformed antibodies. Recipient should be prepared by immunosuppressive therapy and if needed by whole body irradiation. Next comes the donor selection and matching of the donors MSC and blood group. Then MSC 1 and 2 both can be nowadays both can be matched by sequencing. Blood group matching by at least 10 grouping systems and post-transplantation management of the recipient. And so immunosuppressant agents play a very important role in successful transplantation. So we are discussing immunosuppressive agents as well. Immunosuppression can be brought by 3 different ways: surgical ablation, total lymphoid irradiation, and immunosuppressive drugs. Immunosuppressants can also be classified depending on the specific transplant, say Bacillus monoclonal antibody in combination with cyclosporine and corticosteroids are used in kidney transplants. Daclizio monoclonal antibody in combination with cyclosporine and corticosteroids are also used in kidney transplants. Muromonab CD3 along with cyclosporine in kidney, liver, and heart transplants. Tacrolimus is used in liver transplants, is under study for kidney, bone marrow, heart, pancreas, pancreatic, and small bowel transplantation. Mycophenolate is used in kidney, heart, and liver transplant. sirolimus in combination with cyclosporin and corticosteroids in kidney. The drug is also used for treatment of psoriasis. Immunosuppressive therapy, there are monoclonal antibodies to suppress the activity of subpopulation of T cell, T helper, cytotoxic T cell, etc. To block co-stimulatory signals. We know co-stimulatory signals are required to activate T helper cell. An antibody to CD3 molecule of T cell receptor complex result in rapid depletion of mature T cells from circulation. Antibody specific for the high affinity interleukin-2 receptor is expressed only on activated T cell and blocks proliferation of T cells activated in response to the alloantigens of the graft. So antibody against high affinity interleukin-2 receptor is also very specific. Molecules present on the particular T cell subpopulation may also be targeted for immunosuppressive therapy. An antibody to CD4 shown to prolong the graft survival. Antibody specific for implicated cytokine can prolong the survival of the graft. So in conclusion, more than 50,000 people waiting for compatible donor. Genogenic transplantations can be a major issue of research. Xenograft technology, including genetically modified animal, may become a new source of organ supply. Side effects of immunosuppressive agents used for graft need a change of specificity in action and avoiding general immunosuppression. Techniques such as transgenic animal production and wide range of research in this field hope to result in opening a new window for the process of transplantation immunology. So thank you very much for patience hearing.